Overview and Scrutiny Committee. I'd like to inform those present that this meeting is being webcast live and will be capable of repeated viewing. So, declaration of substitutes. Are any members in attendance as substitutes today? Declarations of interest. Do any members wish to declare any interest in relation to any matters included on the agenda? The exclusion of the press and public. We have no part 2 items today, so the press and public won't be excluded, sorry. So the minutes of the meeting held on the 29th of January 2025, the minutes of the Hove meeting are here for approval. Do members agree to the minutes? Councillor Quinn.
Oh yeah, can I just make a point, Chair?
Yeah.
That today we haven't, I think it says it in the minute on page, well, I don't know which page of this, but page 10 I'm looking at. Dr. Allen agreed to provide additional information on the gender split of SGS patients, percentage of patients who chose not to progress, etc. And I just wondered if that had come to you yet. And also, I did ask about, the percentage on before they arrive or when they arrive there on hormone replacement or hormone therapy. Have we had any of that information come from Dr. Allen?
Oh, sorry.
Oh.
No, not yet. I have asked for it, and she's still in the process of pulling things together. So I'll circulate to members when I do have it back from her.
Thank you very much. Thank you.
Thank you. So, anything else? Right. Okay. So, Chair's communications. So we have 2 items on the agenda today. The first item is a presentation on plans to develop the Royal Sussex County Hospital emergency floor, including A&E. I recently had a tour of the hospital and was shown plans to make capital improvements, and I wanted to give the committee the opportunity to explore these also. I'm sure that members may have all sorts of questions that relate to A&E, and I want to keep this session as focused as possible on plans to develop the site and what this will mean for clinical outcomes and patient experience. There will be opportunities to explore other concerns members may have later in the year, but I'm conscious that we won't have the time or all the right NHS colleagues in the room to do justice to issues such as the experience of people with mental health issues who present for treatment at the Royal Sussex County Hospital. The second agenda item is a paper on the NHS palliative care offer to Brighton and Hove residents. This was something that committee members requested following Jo Harvey-Barringer's presentation to Hove last year on the care her partner received in the last weeks of her life. The presentation covers the entirety of the NHS palliative care offer, not just care in hospital. I also wanted to let members know that Councillor Grimshaw and I recently visited the walk-in centre near Brighton Station. We met managers and clinical staff and learnt lots about how the centre works. We were really impressed with what we saw. The walk-in centre is a great resource, and it is important that more people know about it, particularly as a potential alternative to A&E. I also wanted to remind everyone that April is Bowel Cancer Awareness Month. Bowel cancer is one of the most common cancers, but if it is detected early, there are effective treatments available. There is loads of information available online or at your local GP surgery, where you can also order a self-test kit. Finally, we have today, as always, lots of NHS colleagues joining the meeting. I just wanted to remind members that many of our guests are doctors or clinicians, and some of them will be taking time out of their clinics to attend this meeting. To make the most of their time, I would ask committee members to keep their questions and comments on topic and as succinct as possible. So we have public involvement. We have one public question, and this is from Mr. Adrian Hill.
You don't actually have this.
Oh,
Yeah. You just,
is he not online or
he's
anything?
not
No. Okay.
So,
Shall I just not read it out? Or the answer?
yes, we'll provide a response.
Okay.
But we don't read the question then.
Unfortunately, Mr. Hill isn't here, so we'll provide Mr. Hill with a written response. The member involvement. There are no members' questions. So now on to the plans for capital development of Royal Sussex County Hospital Emergency Department. We are joined today by Mark Edwards, Chief of Service Medical Division, and Dr. George Finley, CEO of University Hospital Sussex NHS Foundation Trust. Would you like to present? Thank you.
Good afternoon, everyone.
Afternoon.
My name is Mark Edwards. I'm Chief of Service for the Medicine Division at the Royal Sussex County Hospital and Princess Royal Hospitals. I'm a consultant vascular surgeon by background. We've been asked to come and present to you the investment that the region is making in the ED services at the county hospital and to talk through the staged approach that we've developed to address the concerns that we have around the current infrastructure of the state. Next slide, please. These slides have all been submitted, so you'll have these for your own reference. I think it's fair to say that the emergency departments and the acute floor establishments at the Royal Sussex County Hospital are outdated. I've worked there in some capacity over the last 2 decades in one form or another, and it hasn't changed very much in that period of time. And whilst the rest of the hospital site's been subject to significant investment over the course of the last decade or so, it's the case that the acute floor has not received the same amount of attention. And in that period of time, the models of care and expectations of workforce and of patients have changed. The way that we practice emergency medicine has evolved in that period of time. And of course, it's timely then that we revisit how we're providing that care in that infrastructure. And it's been widely recognised both within the Trust and by others, including the CQC, the Getting It Right First Time group and Enhanced Care Integrated Support Team, that we needed to do some work to address that. That's exactly what we've done. The ICS have provided us, and internally we've identified cash to the tune of £62 million to bring the department up to specification. And that's going to be broken down in a number of different ways. Some of the work's already been completed, some of it's in progress at the moment, and other elements are due to start with a view to full implementation over the course of the coming couple of years. Next slide, please. So there are several strategic objectives here that we have as an organisation. That's to facilitate the modernisation of services, as I've outlined, and develop these new models of care. There's a shift towards trying to provide more of our emergency care in an ambulatory manner and to getting patients to the teams that are going to look after them best in the quickest and most effective ways. So the model of the infrastructure has been established, has been set up with that in mind. We want to improve the capacity in the emergency department. If anyone's been there recently as an ambulatory patient, you'll know that there's particular congestive issues around that because of the increased footfall that we see year on year. The infrastructure hasn't expanded in step with that. So there's a focus on us providing a different space for that. We aim to improve the adjacencies of services, meaning that we're co-locating more and more of our ambulatory pathways in the same area, meaning it's easier to get patients from the front door to the teams that are going to see them most expediently and rapidly and identify their needs earlier in their journey, and to provide detailed radiological tests of increased CT imaging and so forth that will improve the timeliness of their care, and ultimately to improve the environment both for patients and the staff that work there. Next slide, please. Can you go back one? Can you go back a slide? I think we skipped over. Sorry. That's the one. So you'll see on the screen 3 pictures. The first on the left-hand side is a picture taken from an Argus article that ran in 2024, detailing the appearance of what was referred to as corridor care, use of temporary escalation spaces within the NHS is something that's in the press a lot. We're not immune to this concern, and due to poor flow through NHS organisations, generally speaking, the county is not a special case in that regard. However, work that we've undertaken over the course of the last year under my leadership and those of my colleagues have resulted in improved conditions within the emergency department. So the same corridor space that you see on the far left in the middle is a year on. We've introduced a number of programs of work. They're reducing the footfall of patients, reducing the number of conveyances from the local ambulance service, doing work in care homes, and directly integrating our services within the community more directly to try and keep people out of hospital or minimise the amount of time they spend in hospital. Nevertheless, there remain significant challenges on that front. The diagram on the far right is from ADP Architecture, who are the group who've contributed to the design of the new acute floor reconfiguration project, and gives you a flavour of the type of work they've done before and what we're expecting the standard of the investment to produce was. Next slide. So this schematic details where we aim to be in due course. So this is the footprint of the acute floor. I'll walk you through this. The top section in blue is what will become our new medical assessment unit. Above that will be our surgical assessment unit. That come onto that in a minute. The darker red area is our enhanced and expanded resuscitative area of the emergency department. The pink area is what has become what known colloquially as majors. The green area is an enhanced and expanded patient assessment and triage area, first point of call for all but the most severely ill people brought in by ambulance. And then the darker green area to the bottom right is what will be our ambulatory urgent treatment centre. And beneath the pink area, which is referred to as Majors North, there will be an additional area referred to as Majors South, which will meet the capacity needs that we have. That's not part of this programme of work directly, but will be part of the wider reconfiguration work. We've worked across specialties to design this, so this has been something that a number of different clinical groups have contributed to over the course of the last couple of years. Next slide, please. So those areas are outlined, and this just demonstrates that above level 5, we have a level 6 at the Millennium Building, a separate area which is now already established and online as the surgical assessment unit. So surgical patients assessed in A&E will move, when capacity allows, directly over to the surgical assessment area for their needs. Next slide, please. As alluded to, this is a significant body of work, and it's been phased because this is a working A&E department in a busy hospital, which has issues with congestion, which are well described. In order to implement this, we've had to do so in a phased manner. Each of the phases has a detailed plan behind it, some of which is a bit further off. For example, phase 3 is scheduled to start in September 2027, but phase 1 and 1A and 1B are either complete or in progress. So 1A saw the completion of the surgical assessment unit. That's on level 6 in the Millennium Building. That went live last year in the tail end. Phase 1B is the creation of a new medical assessment unit. That's in progress. Works are fully underway, and it's due to open later this year in 2025. That will see the integration of both ambulatory and trolley areas for medical patients coming in. Phase 2 has 2 separate sections: the enabling works, which start in summer of this year, which include reallocation of some of our existing ancillary areas, and then phase 2 proper begins in February 26 next year, once those enabling works are complete, with Resus and Majors North being rebuilt. Phase 3 sees the patient assessment and triage zone and the urgent treatment centre, which are the green areas in this previous diagram, starting to be reworked through. And that's all scheduled to start in 2027. Next slide, please. So a number of challenges that we face. The first of those is around congestion in our urgent treatment centre. The second is around congestion within the hospital as a whole. And the third, as noted already, is the mental health challenge that the county site faces. From a UTC point of view, there are 2 elements to this. There's the physical environment and the pathways and processes. We know that there are insufficient waiting areas for patients who come in, so this particular body of work increases the size of the urgent treatment centre by roughly 100%, so we'll have double the capacity we have to see people walking into hospital. And all of the consultation rooms will be co-located, so there won't be any spread of rooms across the site, which currently they're provided in 2 discrete areas. The UTC pathways are being worked on at the moment. There's a body of work going on within the trust to standardise the way that UTC services are provided across the 4 acute sites that we operate, and that work will support the development of this acute floor reconfiguration. Next slide, please. The second area of concern is that this is a busy slide. Essentially, it talks to the challenge that we have within healthcare as a whole at the moment in moving patients through sites. So A&E is a bellwether for what's going on within the healthcare economy as a whole. So when things aren't working in the community, when things aren't working in the pre-hospital space, it will often be most visible in our EDs. There's a number of points here that are made which basically identify the ways in which we're working as an organisation to integrate with system partners and with other providers to ensure that only those patients who must come to hospital do, and that we do the best by them when they're here and minimise the amount of time they have to spend with us. Next slide, please. And then there's the mental health challenge that's been noted already. We have an area that's set aside in the ED to look after people who present with mental health assessment needs and who are awaiting transfer into beds overseen by Sussex Partnership Foundation Trust. These patients are those who are seen to be medically ready for discharge, don't have any acute medical need to be in hospital. These patients will vary in number in the department at any point in time. In the current iteration of the acute floor reconfiguration plan, there isn't a set aside area for this group of patients, so it's important over the next year that we develop pathways with SPFT partners to reduce the requirement for these patients to be with us in the first instance. Next slide, please. So I'll just step through the design and the phasing. The surgical assessment unit has been established and is now running. The pathways from that mean that patients who attend A&E, whether it's the urgent treatment centre or the main body of the department in majors, can be transferred directly to the surgical assessment unit, which is staffed by surgeons waiting to see patients, and work where their care will continue. It reduces the amount of time that patients spend in the A&E department who've got a surgical need. Next slide. The medical assessment unit work is ongoing at the moment. This large area adjacent to the emergency department proper is roughly twice the size of what we have at the moment for our acute assessment unit. Significant increase in size divided into ambulatory and non-ambulatory elements, meaning that patients can attend with any medical requirement, having been seen and assessed either in the community or in the acute floor by GPs who are appointed by us or by our emergency doctors. And they'll transfer directly there for further ongoing assessment, minimising the amount of time they spend in A&E. Next slide, please. So we recognise that this will all be disruptive. We've got oversight of this with both ourselves and system partners. So we're looking over the course of have developed work with them to optimise attendances and emission avoidance, so minimising footfall to the department and generating awareness with these partners to and patients as they come into the trust to ensure they understand that these phased works are going to change the way that they interact with the acute floor. That's it. Next slide, please. This phase 2, Resus and Majors North, is the main body of the work. So Resus will, in this instance, currently exist where it does at the moment, which is close to the front of the hospital, close to where, on the right-hand side, where the ambulance bays are outlined. The pink area highlighted here is where the subject of the phase 2 work. So Resus will stay where it is, and then the rest of Majors will move into what is currently the acute assessment unit, which is immediately south of that, which will decant into the medical assessment unit as part of that. Next slide, please. The final phase, phase 3, sees the creation of patient assessment and triage area and urgent treatment centre redevelopment in the highlighted areas in green. This will commence in 2027. Next slide, please. Which brings us back to the overall appearance here. So the net gain in terms of space within the department is primarily in the ambulatory pathway area, which meets the needs of these new models of care that we've discussed. There's parallel work, not just you recognise that the changing the infrastructure isn't the solution to all of the challenges that an emergency department faces. We change the processes as well, so lots of work going on this point around how we redirect patients into more appropriate services at the point of first contact and in the pre-hospital arena. Thank you. Next slide. And that's it.
Oh, that's it. Thank you. That was very informative. Thank you. Susie.
Thank you very much, Chair. Thanks for the presentation, but I have a number of comments. First of all, most of us are lay people, and the only thing we understand is A&E. This whole document is completely peppered with acronyms that we don't know anything about. It would have been more helpful if you could just said, well, this is the A&E department. I mean, we don't necessarily need to know all the different things about resus and majors and trauma and stuff. And UTC, what does that even mean? What does UTC mean?
Yeah.
The urgent treatment centre. So currently, I take your points entirely. When I started in my line of work as an A&E doctor back in 2023-24, there was only the A&E come into majors and minors, and that was it. But it's a much more rich landscape of services these days. So we have patients who come in who need the type of work that I do with repairing ruptured aortas, and people who turn up who've got earache, and the department has to cover for all of those eventualities. A significant amount of work nationally is going on around what's called the UTC agenda, which is the Urgent Treatment Centre agenda, co-locating urgent treatment centres which are led by GPs, supported by A&E consultants, means that when patients turn up, we can redirect them into appropriate services for their needs rather than having everyone join the back of the same queue. So we can proportionately triage people out, recognising that these are complex services to run. There's an inevitable amount of complexity in the terminology that goes with it. But UTC, to your last question, is the first point of call for anyone who's got what we consider to be a sort of ambulatory or less urgent medical problem.
That will be people who've walked in as opposed to coming by ambulance. Okay. Now, I'm familiar with drawings, but I was, apart from the fact you can't zoom in because the quality is so bad, I would have liked to have seen where this whole unit fits in with the overall plan of the hospital to see how it relates. Because, I mean, is this over several floors as well? Or is it all on the ground floor? Okay, because that was unclear. I'm sorry. It's just when we're trying to sort of say, oh yes, look at this, isn't it great? When you can't even see it. And my final question is, why wasn't the whole idea of redoing what I shall still call A&E included in the original plans of the hospital? I mean, it seems utterly ludicrous to us seeing all the lovely big hospital built around it, and then what was nothing being done to A&E, and that's one of the things that has always confused me. I mean, having been around this for quite some time, not as detailed as you, but obviously I've been a counsellor for another term as well. And so I remember having one of your colleagues coming in and saying, going through all the exciting phases of the demolition of this and that. But this decision, I don't know, why was it made? And you're going to tell me, hopefully.
So I'll try and take that. So I can't give you the answer because I wasn't involved at that point in time. The business case for the 3Ts was approved in 2014, I think. It's quite a long time ago. And for whatever reason, ED was never included in the business case. So it was just not part of the original business case, neither in phase 1, phase 2 or phase 3. And working with the new hospitals team over the past 3 years, it's never been possible to agree to wrap ED into that. It's very specifically, linked to that business case. What the development has done, though, so this ED development, so it's in situ. So this is redeveloping the emergency department, the A&E department that's already there. That's one of the complexities because we've got to build something new whilst we're treating, 250 to 300 patients a day through that department. That's the volume they go through. But the only reason it's possible now is because the Louisa Martindale building opened, a significant amount of space round about the emergency department became vacated. So we've been able to push the emergency department footprint back into the main hospital more and across into the assessment spaces that Mark's talked about. So whilst the business case didn't give us a new ED, the 3T's business case has given us space to develop an ED, and we've got £62 million to spend to do the best job we can to build the best environment we can for our patients, and that's the that's the job that we're now paying. Can't change history. I can't sort of judge decisions that were made then, but what we can do is deal with what we've got now, which is what we're doing.
Yeah, I suppose, business case, yes, but what about the actual practical case? I mean, this is what, you weren't, none of you were involved in that decision, but it seems to me that, the front-facing thing of a hospital, that people is A&E, and to say, oh no, we can't fit that in the business case, it's just completely bizarre, and I'm surprised that, well, I can't understand it, but is it something that you if you had to go back in time, would you say A&E is one of the most important things we've got to include that in the business case?
So as I said, I can't go back in time and change. A decision was made at a point in time. That's what we're dealt with. So therefore, we've got to make the best of what we've got, and that's what we're doing. And we talk about A&E being the front door of the hospital. That's true. So we see, as I said, 250 patients, or so a day. It's actually not the biggest footfall. So, across our sites, we'll see 1,000 patients a day through A&E. So that's, 350,000 a year. We see 1.2 million patients through our outpatients departments. So actually all of our hospitals are important. Our emergency departments, our outpatient departments, our theatres. Just got to get the balance of investing in them all and delivering what our patients need.
Yeah. Thank you.
Yeah, thanks very much for the presentation. I have to agree with Councillor Cattell. It was, those drawings were actually quite difficult to look at. And I thought with the whole document, it's very dense. It's a very dense document. There's actually an awful lot there. And I can see that you've tried to make it shorter to help us, but some of it would be really helpful, maybe at some point, to have some expansion on some of those points so that we can understand them better. There were particular things that I picked up on, like deeper analysis on why subacute mental health patients with complex needs present to the emergency department. And I'm thinking, well, where else are they meant to go? What do you mean by subacute and complex needs? There's quite a lot in that. And so you're presented with some, the minimum, basically. So that was my first bit. So if you can just say something, because we are all lay people. And it's really helpful to have a deeper understanding with scrutiny. Oh, sorry.
Thank you. There is significant challenge in looking after patients with mental health disease. Nationally, we've talked about that already. What I would also say is that there are different models of practice and care that others have used. So not everything orients around presenting to A&E. Is there attendance? Is a person's attendance in A&E avoidable? Is it a recognition of a set of things that were perhaps missed at earlier points in management? So is there an opportunity in doing the analytical work here to understand why people use the services that we provide in the way that they provide them? And that point there of the deeper analytical bit is to say, actually, let's not just rebuild the building, but understand why people require the building in its current format based on how they are in their own lives. Are things working for them in the community? Are there opportunities to avoid those crises that occur that mean that people present in extremis in A&E in the first place? So it's an opportunity for us to refresh and to reset the way that we approach all of this. And I know SPFT are keenly aware of this challenge. We're working with them on that.
Can I just add? So I think you're right. I always struggle with plans on paper. They're really hard to bring to life, which is why it was really helpful to have Councillor Bowler to be able to walk around the department and we could say, so this is how it is, this is how it's going to look. So there's limitation with what we can share on paper. But what we thought would be helpful was to come to the committee to say, we've had the issues of the environment and crowding. We've taken, kind of the further around the shoulder, but actually to give the wider committee that ability to see, what we're doing to deal with the issues. But I do get the limitations of floor plans because I struggle really to translate them into what that's going to look like. But I think, what we can't do is take all the members of the committee around the emergency department, sadly.
I remember having a tour of the new part of the hospital, and that was hugely informative. I appreciate you can't take us all round, but if some of us were happy to ask you if we could, if there were 2 or 3 of us, or groups, or because it is the thing that people talk about the most, actually, is A&E and their experience in A&E. But I also wanted to ask, because unfortunately, I've had to go twice to A&E, and I now have developed a phobia about going there because it just takes so long and it's overcrowded, and the doctors and so on, they're always brilliant, they're great, but you have to wait for MRI and CT scans because there aren't enough of them. I noticed in the paper that there were going to be more CT scanners available. Will there be more MRI machines available as well? And one of the other things is you don't have enough looms in A&E, and it would be really nice if there were more looms. I know that sounds, but because you're there often for 8, 9, maybe 10 hours, decent looms and more looms might actually be helpful. But I won't go on anymore, but it does get very overcrowded because people are bringing not just themselves, but sometimes a couple of other people with them, or sometimes 3 people. And I've heard them ask people, please can you leave if you're not actually there, because it gets very busy.
No, agree. You've identified the challenge of running a modern healthcare environment and trying to meet the needs of the numbers of people that attend out of infrastructure that was never designed to do that. CTs, yes, but MRI, I don't believe there's a change in the absolute number of MRI scanners that we will have. It's still relatively unusual to need MRI as an emergent intervention or emergent diagnostic test. And there are MRI scanners running 24-hour day, 7 days a week for patients who need them, recognising it is a resource that's always going to be constrained because of the unique nature and the way that it's both undertaken and reported. But CT is something that's now going to be much more readily available. And in fact, the resus area that is going to have its own dedicated CT scanner, which is a real advantage for patients coming in with time-critical illness. On the point of the amenities, that's all being looked at as part of the architectural assessment of the needs of the numbers of people coming through.
Thank you. Raphael.
Thanks. Chair, is it okay if I ask my questions as a block, all sort of, because I've got a number of them, so is it okay if I just ask? Okay, thanks. Yeah, firstly, I just want to say I really welcome this. It's great to see the additional capacity that you're looking to put into this service. I think, yeah, maybe to touch on what we've said before, I think it would have been helpful to have some slightly better quality images in the presentation. I think particularly phase 1A, I couldn't make that out at all. That's on page 12. And yeah, definitely be up for having a look around the emergency department, and I think other members of the committee, I think, would as well. So yeah, there's some positive things there. In terms of there's a review of staffing needed at each phase and to support with service moves. So would you be able to talk a bit about how that will work in terms of the sort of staffing and how it will need to be adjusted whilst you sort of change different parts of A&E at all?
Thank you. There's well documented and publicised staffing quota numbers based on ED departments. These are produced by the College of ED, as well as others. The the key bit here is that at each stage, the number of beds and the number of patients will be used as the guide to the staffing requirements that we have, and that's what we've factored in for each of the phases. But there's anything you want to add to that, Drew?
Yeah, I think the other thing. So I was going through it this morning actually with my chief nurse. We use a safer staffing tool, particularly for the nursing staff. So that looks at numbers and acuity of patients to make sure that you've got the right staff on shift. So I think the point is, as we go through the works, then the numbers of spaces in the department change, and the configuration they change a little bit as well. So we'll use those kind of tools that Mark's talked about, but you also need to layer over professional judgment. So whilst we're doing things that are, slightly makes the department a little bit more fragmented, we might need to augment staffing for a little bit just to make sure that patients are absolutely safe. It's just something we review constantly.
Thanks for that. Yeah, that's helpful to hear. It also mentions talking about a sort of external communication campaign to sort of let people know about this, and also talking about sort of bringing volunteers to wayfaring. So I'm wondering, how can we help with this and sort of communicate things as a council, and sort of what are your plans in terms of external comms for this?
Yeah, so my director of communications is leading on that. He's got links into most of our stakeholders, so I would imagine that that's already happening through Brighton and Hove City Council. But I can check with Jonathan when I go back. I mean, I think the thing that's helpful, because I'm always struck that corporate communications don't get very far. Actually, what gets far is conversations. So actually, the whole point of coming to the Scrutiny Committee is to give you the information that you can have conversations with, as you go about your business, because that's the thing that can make the biggest effect.
Thanks. Yeah, and I'll add, this is also, I think, our first HOSC meeting on YouTube as well. So maybe we'll get some subscribers from this or something. I don't know. But yeah, we want to obviously publicise this as much as we can through our own networks as councillors. I think it's important. I had a question on sort of some of the photos that were used at the start. So there's a photo of 2024 contrasted with January 2025. There's sort of a person thumbs up being like all good, and sort of showing reduced overcrowding. There's been a fair bit of media coverage, I think a couple of months ago, on a sort of doctor role that got recruited to sort of help people in corridors, and that sort of mentioned that caring for older people in the corridor of the ED is sort of normal in our hospital. Obviously, part of the purpose of this whole redesign is to try to resolve this, but it might be fair to say that maybe the January photo isn't fully reflective of all of the experiences throughout January. Would that be fair to say?
So I'll go first, then Mark will go. So you've triggered us both here, so we both want to talk. So ED improvement in the emergency department is not one way; it's lumpy. But we're making significant improvements in both the numbers of patients in the department and the length of time they stay in the department, and a significant reduction in the number of times that patients are in corridors. But we have peaks, so we've just come out of a 4-day bank holiday weekend, and the emergency department's been under a significant more pressure because of that. That is resolving today and will be resolved through the rest of the week. So that picture of an empty corridor, that does not happen every day, 24 hours a day, but it's happening more often and more reliably than it did 12 months ago. And the trajectory of improvement this year from January to now has been a significant reduction in patients that wait over 12 hours in the department, a significant improvement in patients who are seen, treated and discharged within 4 hours. Over the weekend, we were seeing 3/4 of the patients in under 4 hours and either discharging home or admitting to a hospital bed. So it's not fixed at all, but there's a significant improvement programme wrapped around about that Mark's got a significant contribution to make to that, and we're making a difference. So yeah, it's work in progress, but it's something that's really important to us, and we will keep going until we make some improvements. We're always happy to invite colleagues in. We invited our colleagues from Healthwatch in a few weeks ago to do some observations and to give us some feedback, because we do welcome scrutiny, and we welcome sort of that kind of constructive criticism about what we can do more as well.
I don't have much more to add to that, other than that to highlight that the last 90 days or so, we see significant stepwise improvements in corridor occupancy. And it's difficult because it's no one intervention that makes the difference. It's about how we're interacting with system partners, how we're engaging with a whole suite of services, how we're practicing differently as a division, and my team and my doctors are out there doing different things, working in care homes, working in the CCAM acute care navigation hub that's been established. And all of these things incrementally are making a difference, and they're changing the way that we work with others. That seems to be bearing fruit.
Thanks. Those very helpful and helpful to hear that those improvements are being made, even if it's not a consistent picture. I want to touch on something Councillor Quinn mentioned, which is about subacute mental health patients. I think you were wondering sort of what that meant. My understanding, if you might correct me on this, but it's people who are not necessarily at a level of mental health crisis, they need emergency support. And so I'm wondering in terms of, how can we change behaviour to ensure people turning up places that's more appropriate? It might be that you can't fully answer that and it's a deeper analysis needed.
So I think that's a really complex situation. I don't think we've got the right people in the room to have that conversation. I think we probably need primary care. I think we probably need the Mental Health Trust, the Sussex Partnership Trust. It's a conversation I'd welcome. But I do think we need the right people in the room to have that conversation. I'm always reluctant to comment on other people's business. I don't think that's good practice. So I think that would be. I'm not ducking it. I think it's a really important question. I would welcome to have the right people in the room to have that conversation.
Yeah, thank you. We are intending at Future Host, I think in July, we're bringing mental health in young people. And then at another Future Host, we'll be bringing adult mental health. So you can ask more questions on it then.
Yeah, so it's just because it was mentioned in the report.
Yeah, no.
So this is a slightly separate question, but sort of relates to some of your work in sort of changing things in the hospitals after Findlay. So I understand there's a commissioned report, which is a well-led developmental review, which is being done by an external organisation. That report will be ready in May. So I appreciate you not come here to answer questions specifically on this, but I would be keen to know some information about like where that report will be published and sort of what the reasons for that report sort of being made were. Is it in response to the CQC report? And if so, sort of what medical specialism? And are they looking at additional subjects than ones prescribed by the CQC? Appreciate you may not be able to answer that specifically today, but it would be helpful just to get a sense of that as it's going to be published soon.
This is something that we will bring back to HOSC, our Future Host, to ask. I don't think it's relevant to this paper, and I believe that the appropriate people aren't in the room to be able to answer this question. Unless you have anything that you can add to that.
That's probably right. I mean, the thing I can say is this is it's good board governance to invite an external partner to come in and do a developmental well-led review. Recommendations that trusts should do it every 3 to 5 years. University Hospital Sussex is 3 years old, so it felt like a good opportunity to do that. So it's good practice. And again, it's that openness to bring partners in to provide scrutiny, to provide feedback, so that where we know where we can make improvements, we will make improvements. So that's the process of a developmental well-led. It's not an inspection. It's something that the trust commissions as a tool for improvement.
And is that something that will be publicly available in May?
So we'll take that through a public board.
Okay. Thank you. No.
Thank you so much, Chair. Well, first of all, may I welcome this report and welcome the fact that budgets have been established for this to go on. I mean, the history is, you're quite right, Councillors Quinn and Cattell are absolutely right. What a shame this wasn't done, I don't know, when Louisa Martindale was, whatever. And we could go back to Virginia Bottomley deciding that we wouldn't have a new build on the current site of where Millview, the Polyclinic or Falmore was, but we would actually try and redevelop this hospital that we've got up in Kemp Town. But anyway, we are where we are. So I welcome the government putting the money in, even if it's a bit late and it's going to cause mayhem, which it is causing mayhem, because you've actually said that. And everything that's been said about communication and so on and so on is really, really important. Because if you thought it was going to be bad, I mean, we haven't got the bad bit yet. You've actually said in this report that September 25 is when the really bad bit comes. That what we've had at the moment, the medical assessment bit, is nothing compared to what is coming down the road. Can I just pick up on something that Councillor Hill asked about, which was the corridor ward, because that does seem to affect older people quite a lot. And obviously I sit as a rep of the older people. You're all going to get old, God willing, or him up there up willing, or them up there. Sorry, don't mean to offend. But, you know, you are going to get old. So you'll all be. I was a little bit, I don't know whether I'm reassured or not reassured by the pictures or what have you. It looks as if you're saying, but please clarify for me, that corridor care is you know, we're moving on from that, and we're not using that to assess people on A&E. So please, can you clarify that one? The thing I was also going to ask about, I'm sorry, was the mental health issue, which I'm looking at the report on page 16, the challenge, and I've heard that. Now I'm going to dazzle you with a few more initials here. Not mentioned here, so congratulations, section 136. So 136 is a place of safety order when folk are having a bit of a time of it in the community. We might want to hospitalise them through that route, and you put them in what is called a place of safety. Now, in historical terms, places of safety were in police stations and that's considered, quite rightly, not an appropriate place to be. So places of safety do exist in our specialist mental health hospitals around Sussex. But there's only one locally in Brighton, and that's at Millview. And sometimes there are more challenges than that and more patients needing it. So you will see in that block on your presentation, it's page 16, I don't know, it says, how is this addressed? There are 3 specially designed mental health rooms in Major North. I'm kind of assuming they are what I would recognise as a section 136 thing. But, Emma, who is even more knows about these things than me, is shaking her head. So anyway, what I'm obviously slightly concerned about is the impact of having to take patients of whatever description, and you've obviously talked about subacute mental health patients who whatever, patients who need some kind of hospitalisation, who've either presented at A&E or have been sent because the place of safety is no longer there at Millview because it's occupied, or whatever. And what I'm concerned is the impact on other clinical. I mean, you know, clearly you've not exactly got a spare, you know, for people sitting around waiting for people to just turn up. So that's what, I mean, I think you get the picture. So can you give any reassurance about that, or are they likely to be blocking beds or what have you? Oh, sorry, yes.
So to clarify, the issue of so-called corridor care, or the use of temporary escalation spaces, is reducing over the course of the last year. Number of initiatives that we've undertaken within the division I'm responsible for, and the trust more broadly has seen stepwise reduction in the dependency on use of that space over the course of time. We now have many days where a good proportion of the day there is no one in a temporary escalation space, which is different to where we were this time last year. So to your point, very specifically, yes, that situation is improving. On the point of the mental health bit, the 3 areas that have been identified, we will always have, and as all A&Es do, a proportion of patients who turn up who have mental health requirements, medical and maybe medical issues alongside of that as well. So that it's right and proper that a proportion of patients do attend A&E for assessment at that point in time. Those rooms have been designed and are free of ligature risk and so forth, which means they're appropriate for use for that group of patients, but they're not for holding areas for any length of time. These are for people who are coming in who've got medical requirements to be assessed.
Can I just add a couple of other things? So So to be clear, the funding for this development is system funding. It's capital funding that is supported by the Integrated Care Board and by our own capital funds. There's no extra funding coming from government. So we've chosen to prioritise the capital that we have to do this. So it's a choice, but one that we felt was really, really important, and NHS Sussex colleagues felt was really important. So we've chosen to do that. And on the sort of mental health, patients presenting mental health crisis, they will always come to ED. The work that we're doing with colleagues is how do we ensure that they can leave ED rapidly. It's really interesting, and I think we talked to Councillor Fowler about it when she was there. The crowding in ED is about patients waiting to leave. It's not about patients waiting to get in or get treated. Primarily, people come into ED very quickly. We offload ambulances. Their time to triage is 15 minutes. Their time to treatment is less than 60 minutes. And when people are waiting in the emergency department, they've been assessed, treated, and treatment's been started normally. It's waiting to move on. So actually, that's what we're trying to deal with, both for mental health patients and for physical health patients, is to move them through the department quicker. And that's the work that we're doing with the Partnership Trust as well.
Thank you. Laura.
Thank you very much, Chair. Thank you very much for your presentation. I'm here on behalf of the community voluntary sector, so I'm a community works rep. And I've got a couple of questions. I've got 3 questions. A follow-on question on the staffing. So when it gets really busy in A&E, or I still call it A&E as well, but ED, is it then when staff from other departments are being brought in, basically, to bring down to get the work done a bit quicker? Oh, sorry.
Thank you. Every day we have regular meetings through the course of the day, sort of system, business as usual meetings within the site, to look at where the demand is, if there are shortfalls in staffing, or if the situation has exceeded what any one group can look after. Yes, there is a call for support from different areas, and there's a proportionate review of where staffing is to make sure that we're balancing the risk across all clinical areas within the site.
And I think just to add to that, we've uplifted the establishment in ED. So recognising the emergency departments have more patients in it than we would want, we've put additional staff into the emergency departments, a baselining issue. That's a cost pressure, but it's something we felt was important, so that we pay attention to care, dignity and safety.
So I'm assuming that's, for instance, the bank holiday weekend is coming up. You, from history, from experience, it gets busier, or like the weekends, it gets busier. Is that when you then bring in some more staff?
So that's more the function of the site, the regular site meetings that Mark's talked about. We look at that on a shift by shift basis and do a risk assessment across the hospital. Where are the pressures and where do we need to deploy staff from? We use quite a lot of bank staff as well. So if we can see that the next shift's going to be very difficult, we can go out for additional bank staff. And so it's a very dynamic thing that is managed through the site team and the nurse leadership.
Question from one of my colleagues: how will you address the issues of people coming to ED by themselves, i.e. not in an ambulance? And are they expected to come through the new building via the entrance on Eastern Road? Because you find that people who come in by on foot or by bus, that for some people it's quite a struggle to go up the hill. So are you part of the reconstruction, and is that something that you've also looked at?
So it's a difficult site, isn't it? It's complex. It's multiple buildings. It's on a hill. It's not ideal for patients going on. We recognise that. So the plans that Mark's talked through show the new UTC building. That's where we expect most walk-in patients to present to. So walk-ins will come through the UTC, the Urgent Treatment Centre, rather than the main ED. So that entrance will be up near the front of the current ED. So we still expect patients to find their way that way. And there will be access through the Louisa Martindale building as well. We've just refreshed all of our signage in the Louisa Martindale building to try and make it easy, based on the feedback we've had that it's too difficult. so that we can make it easier. But there's very little we can do about the distance on site and the fact that it's on a hill, other than to try and be really clear about signposts and be clear about drop-off areas as well for patients that have got difficulty with mobility.
No, sorry, could you have your mic on?
Oh, sorry. It's so annoying with this thing. Sorry. So there will be a way in that is maybe easier for some people, maybe who struggle walking up the hill. I mean, I'm assuming there'll still be a bit of a hill or something, or.
As you come in the main entrance of the Louisa Martindale building, you can access the lifts just behind the main entrance and that take you up to the 6th floor. That's then step-free route round to the back of the Thomas Kemp Tower where the UTC is. So there is a route. It's complex, but that's the nature of the site.
And the final question is it's again about the space inside. We know that at the moment the space in ED is quite cramped, and that's why we have a lot of also the trolley care or the corridor care, as you called it. In terms of reconfiguring that space, are there going to be like bays, or how's it going to look like? Because I couldn't get that very clear from the pictures.
Thank you. Yeah, so Majors North will have individual rooms set aside so to meet latest regulations around infection prevention control and the space that needs to be allocated to those areas.
So I think it gives us a bit more space and it gives us more privacy and dignity. It gives each of the individual patient spaces are bigger. So if you come to our current resuscitation room, it's tiny. And it's really not fit for purpose for modern standards. So yes, we increase the number of resuscitation spaces, but the actual size of each space increases significantly. Paradoxically, we don't really want more patients in our emergency department. We don't want a bigger department to hold more patients there. The departments, with the changes that we'll make, will be the right size. That's contingent on flow. So emergency department crowding isn't about more patients are coming to ED. It's about difficulty in leaving ED. As I've said, it's a queue to leave. So as well as the building, which is important, some of the processes that Mark's talked about managing demand differently, that's the importance of our assessment spaces are that you can leave ED quickly to go to a medical assessment space or a surgical assessment space. That pathway stuff is really, really important. And that finally links us all to discharging from hospital as well. We've got to be able to reliably discharge patients from hospital when they're ready to leave, so that the emergency department can empty into the hospital, into beds.
So can I then, does it mean that the corridor care that, for instance, when I went to A&E once to visit someone who was there, that another patient was seen by someone and they just put something around them, but it was still, they could still, you could still see. So if we were sitting on one side, you could actually see inside and see what's happening, and that was quite undignified for the patient, I would say. I would feel very uncomfortable if that happened to me. Is that what you mean, like that won't be happening anymore?
Yeah, so two things. The rebuild is a phase thing, and it's a bit away. But when we get to that final footprint, there'll be much more privacy and dignity for patients because of the way it's set up. But we've got what we've got just now. So the key intervention is to not have to put patients in corridors. And that's the whole point. That's the whole work that we've been doing. Really, really focuses for quite some time, but really, really sort of accelerated that program of improvement over this year. So I think we're in a place to say we're going to soon have very much a zero tolerance for corridor care. It should not happen because we'll have enough alternatives to admission, managing demand in a different way. Managing flow through hospitals in a different way. And those processes that we're redefining will then mean when we move into a new ED, it will work even better. So I think it's both. It's not just the building, it's the processes that we need to put alongside it. And that's the work that we're doing just now. So I'm really proud of the work the teams have done to make significant reductions in patients that need to be cared for in corridors, because it is undignified. It's not right. It's not safe as it could be. And this is a key safety issue for me. It's not a performance issue. It's not about 4-hour stand-up performance. It's a key safety issue, patient experience issue, and staff experience issue, which is why we're pursuing it really aggressively to make sure that we can get to a place where we just do not have patients in corridors.
Okay. Councillor Wilkinson.
Thank you, Chair. And like other colleagues, I'd like to thank you for coming along today and presenting as you have. I do appreciate the constraints on your time, so I'll be quite brief in my questions. I've only just got one main question that jumps out at me, and it focuses in on one of the challenges that you highlight in your presentation, which refers to the overcrowding in the A&E department and also meeting the 4-hour performance target. And in doing so, you look at how the design of the department will potentially contribute to reducing those challenges. And in particular, you do highlight one of the challenges being the insufficient patient assessment and triage, otherwise known as PAT as an acronym, spaces, and also the lack of resource capacity. And then I see in your presentation, the design mechanism to address this is to increase the pad capacity from 5 to 7 cubicles, and in terms of the resource, to expand it from 3 cubicles, albeit 5 to 8. So I guess the question is really, is that going to be enough to address, or at least make a significant contribution to addressing the overcrowding and the 4-hour target performance indicator? Thank you.
Thank you for the question. The majority of the 4-hour standard is met through the patient group that walk in and walk out, who don't need admission into hospital. They need assessment, rapid treatment, and then to go home and be fed into other community services. That group of patients primarily will be the group that are going through the UTC area, which we're increasing quite significantly. That's the urgent treatment centre, so-called minors, if you like, in old money. That group will have access to a different size of service, like the size of infrastructure. So they will be, the capacity to manage that group is going to be improved. So we will expect to see improvements in the 4-hour standard based solely on the improvement in that one patient group. The increase to PAT will support this because there'll be better turnover of patients through that early assessment phase of their management within the department, meaning they can be triaged into different areas more rapidly. So that might be that they go to the medical assessment unit or to the surgical assessment unit, or indeed to UTC if their care requires something that doesn't need them in a trolley, for example. So it will give us much more ownership over that very first moment and point of contact with senior decision makers right at the very front of the process. The issue around resus doesn't make a great deal of difference to the 4-hour standard. These patients, we just need more capacity to look after that group of people who have very time critical, high monitoring requirements, of which are a great number, given that we're a tertiary centre with a major trauma interest, and a number of patients who will come to us who need to be hosted in that kind of environment at the moment. As George has already said, that space is very limited, and as colleagues who've been into the department will know, it's not at all fit for what we need it to be at the moment. That won't have a direct bearing on the 4-hour bit, but the other areas will do.
Thank you. That's really useful context. I guess what I'm really hinting at is, if I was a consultant or a doctor in this area, would I want more cubicles? Is that sufficient in terms of why it's addressing the design, or is that all that the design can fit in because of the mitigation factors? Thank you.
It's the design that our team came up with, so they themselves have been, the consultants have been involved with that. And when I've spoken about this, because my thoughts initially when I came to this was surely we just need a lot of space, as George has already said. In actual fact, what you don't want is a big ED, because then there's a temptation that it just gets filled. What you want is a tightly functioning high performance ED that's got lots of avenues to pass patients into to get them through quickly to the services that they need. And that's the aim of the team. They would prefer a lean space rather than an expansive space, and this fits that brief.
Okay, thank you. Jeffrey.
Thanks very much for coming in. And I welcome this report because we've had enough interim view visits from Healthwatch pointing out some of the weaknesses, and I'm hopeful that these will be addressed by this long-term project. My question really is about the money. In March 2022, to a great fanfare, there was an announcement that 48 million had been found, and everyone was saying hallelujah. Since then, it's gone up 14 million. I'd like to have the name of your suppliers of sofas, because obviously you found extra money. I know you said capital funding has been raided. What is going to be sacrificed with that 14 million? And are you with the increase in building costs and materials? Are you confident you're going to have enough money to see the project through to 2027? Answers on a postcard or here.
No, it's a great question. So, like, it's a lot of money. 48 million is a huge amount of capital. And the challenge of major capital works just now that run over multiple years as inflation has been eye-watering, and the price of supplies has outstripped even inflation. So we've had to consider that. And there were some options. You know, we could have scaled back the ambition of the project to keep the cost within 48 million. We felt that was a poor option because we'd spend a lot of money to build something that wasn't fit for purpose and wouldn't resolve the issues that we wanted to resolve. The benefit of it being a multi-year program is that we can make some choices about our annual capital allocation over 3-4 years and put a small amount of that capital in each year to make the difference. So sadly, no sofas. No sacks of money tucked under desks or in bottom drawers. But again, we've just had to make a choice that we have roughly £100 million of capital per year, which to spend. So to supplement the 48 to get to the 62 has meant a small amount of capital over a recurrent basis for a number of years to build that project. We'll keep it under review. We clearly want to keep the costs down as low as possible. We want to build it as quickly as possible. The timeline's challenging because of the running a department whilst you're building a new department's a challenge. But we're always challenging ourselves. Can we bring some of that forward? Because we know that we would just want it delivered as quickly. So that's the reality of the money. But the important thing is we end up with a really high functioning fit for purpose ED, not one that fits within £48 million that doesn't do what we wanted to do. So we've made some choices on that, Jeffrey.
Thank you.
And thank you for that. I would just comment that some of these acronyms that were questioned, they're all in full in the report. Journalistic practice. The thing is in full and then it's done as an acronym later on in the report. You just have to read the report and it's there. So thanks for the report again.
Okay, thank you. Any more questions? Thank you. Okay, thank you very much for bringing that. I just want to say thank you also for taking me round the department, and it was really great to see the surgical assessment unit working, which has taken some of the patients away, from the corridor, and it was great to see that in person. So, just one small question. I just want to make sure that we're all on track for this to be finished by 2027.
Yeah, we're currently on track. So phase 1 delivered, medical assessment unit on track for later this year. As I said, I'm pushing the capital team to see whether we can bring any of it forward. So currently, I don't think there's any risk to that programme, and I do want to sort of see whether there's any opportunity just to bring it forward a little bit.
Okay, brilliant. Thank you for the time. Thank you. I'm going to call a 10-minute break now. That's okay. Sorry, welcome back. We are joined today by Lola Banjoko, NHS Sussex, who will present, and by Steve Bath, lead nurse, palliative and end-of-life care, University Hospital Sussex, NHS Foundation Trust. Lisa O'Hara, nurse consultant, palliative and end-of-life care, Sussex Community Foundation Trust. Lisa Barrett, Chief of Nursing Care from Southern Hospice Group, and Taragita Walker, Deputy Director, All Age Continuing Care at NHS Sussex. Thank you. If you would like to present.
I'll start. Thank you very much for the introduction. And just to say, I also have Adam Husak, who's from Community Healthcare, and Helen Cobb, who's really kept us all in shape and in order to make sure that we're here today. So thank you very much for inviting us. As you can see, we have representation from virtually every provider that is involved in providing palliative end-of-life care, very vital and critical service for people who are at the end of life. What I will do is just give you headlines, because I'm going to take the paper as read. And we do welcome questions from the councillors. So the paper actually describes a multi-agency service delivery and how we work together collaboratively across all providers. And you would have seen that evidence in the case study that is in the paper. This is really, what underpins the service is really personalized care. It's about individuals, their family, what they need from a clinical and non-clinical perspective. And the whole aim is to ensure that our collective aim is to ensure that in Sussex, we make people at the last stage of their life have a good as possible exit in terms of dying well. How we can do that together, confidently, honestly, and consistently to help each person and the people that matter to them to have a good, what we would describe as good dying. Right from identifying people through primary care, you would have seen that in the paper, to the care provided by our community providers, by the acute providers, by the hospice, and continuing healthcare, as well as the many volunteers who support this service. We actually ensure that we can do as best as we can. We recognize that there is more work to be done, and we're working through that to ensure that we continually improve. So what I'm going to do is hand back to the chair, because I would welcome my colleagues being given the opportunity to actually speak. As you've introduced them, they're all, the clinicians who deliver the service.
Thank you. Was anybody else want to say anything else, or should I just go straight to questions? Yeah, okay. Councillor Quinn.
Yeah, I thought this was a fantastic report, very much welcoming. I think we had someone who came to OSC where there was much discussion about end-of-life care, which had been problematic for many reasons. But what I particularly really liked about this, I loved the policy of respect. Because I think that's incredibly important to end of life, to have your wishes listened to. And with the you did a case study, and it really came across that tremendous effort had been made to support somebody who obviously had quite a lot of, I can put it, complex needs regarding their end of life care. But the thing I particularly wanted to draw attention to was how delighted I am that the all age continuing care service purchased bed capacity at Marlow. And so they got 6 beds were commissioned. And it's saying this approach ensures high quality provision of end of life care for patients. And it also provides a stream of long-term financial security for hospices. And to me, that's really important because hospices struggle so much to raise the money that they need. And what I was going to comment on was the fact that with hospices now involved with these other services, where you're obviously very much this partnership working, that's so important. They must have brought quite a lot of experience to the table for the other groups they're with, because of course they've dealt with so much. I know my brother died in hospice, and I mean this is many years ago, but the treatment was excellent. And my mum used to go sometimes for respite care to a hospice, and I'm really pleased to see this. And essentially, do you see this as sort of actually becoming something that increases over time, that you would actually be in a position to buy more beds in places to provide more money? Because I certainly see that as the way forward. If there is the money.
Can I just say thank you, Jackie? I was meant to say, can people introduce themselves and say who they are? Because we've got new people here that have never been to HOS and they don't know who we are. So I would like people to just say what role they play in HOS before they ask a question. Thank you.
Well, I'm a counsellor, Jackie O'Quinn, and I've been a member of HOS off and on for 10 years, since 2015. And I also chair the People Overview and Scrutiny Committee, which deals with, amongst other things, adult social care. And so I have a lot of interest in this area, and it marries up very well with my involvement on this particular committee. Thank you.
Only if you ask a question.
So thank you. So I'm Lisa Barrett, Chief of Nursing and Care for Southern Hospice Group, which Martlets is one of our sites. So yes, we are very pleased to have been able to work with the ICB to implement these beds at the Martlets. There are 6 beds in total at the Martlet site, which is obviously where we're talking about tonight. Those beds are slightly different to our specialist palliative care beds in that they are beds for people who meet the requirements of CHC fast track funding. So they're rapidly deteriorating in the last 12 weeks of life, but wouldn't necessarily have specialist palliative care needs. So historically wouldn't necessarily have come to the hospice. We are very keen to support a wider contingent of patients who require some level of palliative input that can't be provided in the home, and it also does help with our finances moving forward. And we're very keen, though, to work and are working on going with the ICB to look at how we can also support more effectively our specialist palliative care provision, which is potentially more challenging, but we are very much working collaboratively to look at how we can sustain that.
To hear.
Thanks, Chair.
Thank you, Chair, and thank you, Councillor. My name is Terry Tegamard, I'm Interim Director for All Age Continuing Care. So, yes, we were very pleased to purchase the 6 beds and work with our hospice colleagues. This means that individuals who are CHC funded and are rapidly deteriorating would have a better experience because they would have access to hospice professionals, which is, better quality of care for us. We do indeed also work with Martlet Care, which is the home care provision as well, as you will have seen in the paper, again improving the quality of care received at end of life. Thank you.
Thank you. Gary.
Thank you, Chair. I'm Councillor Gary Wilkinson, been on HOSC for a number of years, and I'm Deputy Chair of the Scrutiny Committee. Pleased to meet you all, and thank you for your presentation and the paperwork that came with it, which was most welcome and give good context of all the services that you provide. And in doing so, I welcome you here all as providers. And then, as I said in the paper, you talk about the current services that are offered. What I haven't got a grasp of, and it raises a question for me, is how integrated all of you are mean, there's many of you sitting around the table, but in terms of the offer we give as a city to palliative care and end of life, I would just like some feedback as to how you work in a multidisciplinary way. I think it's really important for users, families, and carers to understand that you do work in a multidisciplinary, integrated way. And I have a number of questions coming out of that. For example, who leads in the multidisciplinary team? In particular, when both health and social care services are combined, does anybody take a particular lead in coordinating the palliative care or end of life service in that respect? And to what degree are your different settings able to share information between yourselves? Which is crucial. So I had so many questions, and I know the chair made the point of us being needing to keep our questions quite succinct. But after all, this is a scrutiny committee. So what I may well do, if you're receptive, is send some questions on to you in a written form, not to take up too much time from you today. So I'll just pause there. I'll just ask that basic groundbreaking question before perhaps letting other colleagues and councillors come in. But I'm just interested in how you all work together, and is there a joint point of contact between yourselves and also, as I say, for families, carers and service users that makes me feel you are integrated as opposed to just being disparate groups. Thank you.
Thank you for the question, Gary. So I'm Steve Bass. I'm the lead nurse for palliative and end of life care for UH Sussex as a whole trust, but primarily my career started at the Royal Sussex County Hospital. And I think for Brighton and Hove users, it's really important to realise that the multidisciplinary approach that you would want to take from the acute setting is something that is fundamental within our palliative care team. So the palliative care team in Brighton alone has the clinical nurse specialists and the doctors that you would expect as part of that team. We also have our occupational therapists, so those extra AHPs working with us to ensure that the holistic care of the patients that are living with a progressive life-limiting illness get that right approach. That is coordinated from the acute, from the hub of the palliative care team. They liaise very closely with the wards who are essentially in charge of the care of the person that we're helping support. So we tap into the services on the wards themselves. So that's where we would look at getting the support from the physiotherapists, the dietitians, etc. One of the things that's really important and key to that, and I think is at the point of your question, is how do we all communicate? And I think in the years that we've been collaborating with the ICB and its predecessor, many of us on the table have shared different roles within that. And I think it's come together as part of the NHS Sussex Palliative Care Oversight Group that looks at us all from a governance perspective. From that, what happens is the likes of Lisa, I, Terry Teager all form little further operational groups, especially for within our services, so that the teams that we lead on are all communicating. So on a daily basis, as we said in the report, my team in Brighton will liaise with Lisa's team at the Martlets, but we'll also liaise with our team up at St Peter's, St James, or if necessary, out to our other colleagues at St Barnabas House Hospice, whichever hospice we need to share that, providing that same level of care with. Lisa and I have worked for many years together, making sure that those patients that have a progressive life-limiting illness that might not necessarily need specialist support are getting the right level of assistance and assurance, so that the district nurses know about those patients as well that are coming out of the acute, so that we're trying as best we can to safety net the person that's leaving hospital that is living in the last phase of their life, to the point where we're also, and she's not with us today, but another colleague of ours from CCAM, we've set up systems so that we can alert CCAM to a person living at home that requires palliative care. At that point, I'm going to stop talking because I do talk quite a lot, and I'm going to pass over to Lisa that she can follow up on, which means I'm not going to press the button so she can talk.
Hi everyone, thanks for inviting us. My name's Lisa O'Hara and I'm the nurse consultant for palliative and end-of-life care at Sussex Community Foundation Trust. Just to follow on from what Steve said, we really thank you for your question, because the MDT and the collaborative working between all of us is one of the most important parts of our roles. Certainly my role is very rewarding, and I feel that patients get a very, very good service from the meetings that we have and the discussions we have working together. Myself, from a community provider, I meet with Steve every fortnight, and we discuss issues that come up or how we can. We're always looking for how we can improve things with no money. So looking to develop where we can, to improve the patient pathway. We have weekly meetings with our hospice provider, our district nurses, all the different teams in the community meet with the Martlets every week. And we highlight and discuss any patients that may be deteriorating quickly or we're concerned about, or who may need an extra bit of care there. And with the ICB, we work very, very closely as a system, is what I'm saying, really. And I think that's one of the brilliant things about how our palliative system works in Brighton and Hove. We've got very, very good relationships with each other. And as Steve said, with CCAM as well. And with regards to the Respect escalation plans, the ICB managed to find some money in the last couple of years to fund a post. We're national leaders in training of Respect, actually. And we provided all of the system training over the last 3 years to really get people robustly trained up and be able to complete emergency escalation plans, but not only complete them, make them very meaningful. So we would work very closely with our paramedic practitioner, CCAM ambulance provider, so that if someone was admitted into hospital, we would then meet and look at what was that an appropriate admission? Is there anything we could have done to prevent that admission? And then we would look at the contents of that Respect escalation plan and see if we can improve on it. And then we feed back to the individual who wrote that plan. So, and I'm very pleased to say we're able to fund that post permanently now. So we have a Respect trainer. We've spoken in Northern Ireland around that. So Brighton and Hove are very well set up in that area. I mean, I think I talk quite a lot now as well, now that I've started. So I won't keep going on, but yeah, thank you.
Thank you.
Thank you very much, and thank you for sharing that. I guess the question I'm asking is not a criticism, it's more I'm just actually trying to find out, to scrutinise, is that, for example, your 5-year strategy talks about integrating the services and integrating care. We know that leads to a more effective care. And you're all joined up, you all have links with each other, but there is no single centre point of coordination as far as I'm seeing in this report. Am I missing something? Is there a lead person, lead organisation that coordinates palliative and end-of-life care and coordinates it across the city, or do you just all work through your connections and joined up approach?
Thank you, Councillor. So where we are at the moment, obviously, is we rely on relationships, on collaboration. Where we're shifting to is as part of our neighbourhood health, and I don't know if you're aware about the neighbourhood health that we're doing in Brighton and Hove, working with the local authority and all our partners. Is in Brighton we have it's one neighbourhood. But I would describe it, unless Steve tells me otherwise, as 3 hub and spokes that we work across Brighton. And the whole idea is we will be having an integrated, it's part of the government's drive to shift care from hospitals to community, which will be the ambition in this sort of topic we're looking at, but also to improve on the use of digital and also prevention. Now, from palliative end-of-life care, the ambition is to have, working with GPs and the hospice, UHSX as the specialist outreach and the community, have an integrated team that actually leads around a case, sort of a case note, so that there's a structure to it, and it's called neighborhood health, so that we move from collaboration to actually shared outcomes and shared accountability. And that's work in progress. We're still in the early stages of that structure being in place. And one of the areas where we're looking to pilot it is probably in, where is it, Helen? In Crawley. But as a pilot site, and then we'll sort of cascade it across Sussex. So the question you're asking in terms of shifting from collaboration to actually making sure the structures, irrespective of who's there, makes it work, is the neighborhood health. Julie.
That's right. Thank you. Did you just say me, didn't you, or Teresa?
Did you have your hand up? But I've got Julie next.
Oh,
sorry, I didn't see your hand, Julie.
Thank you. Hello, I'm Councillor Julie Cattell, and the ward that I represent, one of the people in the ward is the person who came to us with her horrible story about how her wife was treated at end of life, and I've become reasonably good friends with her, and so it was hot. And I think the thing is, Joe's wife must have fallen through the cracks in a way, because she developed liver disease, and she wasn't a drinker. She didn't drink, and she wasn't, but she wasn't treated with the respect that she should. Some of the medical staff around her were sort of calling her a naughty girl for being a drinker and stuff like that, which is why we asked for this to come, because that. I mean, how did that happen? I mean, I think it happened very quickly. And so she went in for a few tests and deteriorated quite quickly. So there might not have been enough time for that kind of communication to evolve. But so I think that there must be something about getting some of the medical staff to treat people who are about to go into your service or could go into your service with the respect that they deserve, because that was such a horrible example, wasn't it? Yeah. Thank you.
I think I'll just come back on that as well, because I think what was lacking in her case was the palliative care. Yes. Because she was in hospital and she was dying of liver disease, which wasn't anything to do with cancer, and it wasn't anything to do with drinking, but people who didn't know her were coming in, and she had different treatment at all times, and that was in hospital. So I think that's what we're concerned about, is the hospital palliative care, that people were treated with the respect. I think she was also vegan, and she was given with a drip food that wasn't vegan, which made her ill as well. So there was lots of little things that they came to both of us with, isn't it? Thank you.
I'll come in there. I was part of. I know from that meeting that Joe came to, I was first and foremost part of Professor Roach's committee to meet with Joe in the hospital from a palliative care perspective. And I think one of the things that we spoke about with Joe was that the challenge within that particular case, which is a national problem, which is highlighted within the report as well. And I can talk a little bit about the NCPOD, and apologies for the acronym, but it's the national way of auditing parts. They've looked at palliative care in the acute as well. And I think one of the things that we knew, we met Joe quite late from a palliative care team's perspective. We didn't meet that particular person until they'd left ITU and had been already given quite a sad and limited prognosis. So we met them quite late. And with the limited service that we had at the time, we were only able to do so much within the expectations of the holistic care for Joe. And so we attempted to do the best we could. And part of that was ensuring that she was tapped in with the hospice when she left hospital, with a view that she might be able to go there. The reason I say that is it highlights to us that palliative care is often misunderstood in the acute setting and in the community, that we only look after cancer patients, and we don't. It's on a need basis. So if somebody needs us, we will come and see them. But the challenge we have is lots of people now need us. So we only have a very limited service. So we have to prioritise who we're going to go and see, and try and meet their complex palliative care needs from a symptom perspective, and then from a more holistic needs perspective. One of the things that came from Joe, and when we all met, was a conversation and an action plan from Professor Roach as to how we're going to deal with the problem, how we're going to deal with some of the communication issues that happen within our hospital from our senior colleagues in terms of how they behave. So we developed alongside the national recommendations what we're going to try and do. And one of the things that, interestingly, again, Lisa and I are working on is the liver disease pathway for patients in and out of hospital. We know from our colleagues in West Sussex, it works really, really well. And we actually have a national benchmarking from Worthing Hospital of where we can look after somebody with a non-malignant disease, so a non-cancer disease like cirrhosis of the liver. And by providing the right MDT approach, we can minimise their crisis admissions into hospital and indeed dying in hospital. And that was in collaboration with St Barnabas House Hospice, who is the other part of Lisa's hospice remit. So we know we can do it there. So one of the things from Professor Roach was, how can we do it in Brighton as well? How can we extend those similar kind of multi-professional ways of working? So we're just starting to work out how we collaborate to do that, again, within the limited resource that we have, to be able to provide the right holistic care to the right person at the right time, irrespective of their diagnosis. And that is really key. And I know that one of the places we oftentimes meet patients in crisis in the acute floor, so we want to make sure that we have a subset of our team constantly going to the acute floor, so the emergency department and all of those wonderful places that George and Mark told you about earlier. We want to make sure we're there as well, so that we pick those patients up sooner rather than later. And I think that what you heard, a very tragic story, is one that's not just a local phenomenon, it is a national phenomenon. Does that answer your question?
Anything to help you? Yeah, thank you very much. I'm sorry, I wasn't actually. I was away at the meeting where Joe came along. It's very confusing because Joe and her wife both called Joe. Just to confuse her. Yeah, I wasn't here at the meeting, but I'd obviously heard the story. So, and I didn't realise that you knew so much about it, because obviously as you say, you got there sort of right at the tail end of it, and I'm really pleased and heartened to hear that you are capturing people, at that right time. And it's not just about the cancer care; it's about anybody who needs end of life. So that's that's brilliant. Thank you very much for that.
Okay. Teresa.
Thank you. Thank you for all of your contributions. And I'm following up from Councillor Wilkinson's questions, really, with regard to there are multiple strands of people who are coming together to provide a holistic team approach to helping people at that life stage and to provide palliative care. I just asking, have you got robust evaluation systems in place to ensure that the various members of the team that will coalesce come together and are being effective? So can I just clarify, do you mean from a patient perspective? Are we getting feedback from patients, or do you mean how we are working together as professionals and evaluation of our roles as professionals?
I'm thinking from both perspectives, obviously from the recipient of your care, that is absolutely important, but also in terms of the service, how effective that is. Are you evaluating how effective your communications, bringing together all of the team members?
So from a patient perspective, actually there is work to do on joining that up, because we work across multiple areas, as you realise. So we will all do patient experience surveys. Certainly we do in the hospices, and I know that in the hospital there are patient experience services surveys also being carried out as well. I think finding a way to work to improve that. So from my perspective in the hospices, we have 3 hospices that sit within our remit, and I appreciate this is about Brighton and Hove, but certainly we're looking at how we capture that experience across the 3 hospices, and so we get almost a more powerful amount of data that helps us really see how our services are working. From a professional, how we evaluate the services that we provide, well, that's the patient feedback, but also we liaise, certainly Steve and I liaise a huge amount around those pathways between hospitals and into the community, because we provide significant amount of community palliative care support as well as the inpatient beds that we have. So we do a lot of work looking at where there are challenges to that, where there's blockers, where pathways haven't worked as well as they should. So we will do that work, and there's a piece of work we're trying to do currently looking at some of the challenges to how we can standardise across Sussex to a certain degree, our referral process into the hospices, because we recognise that Sussex sits across a wide part, the majority of Sussex in reality, from an acute trust perspective. But the hospices, that therefore there's several hospices that Steve's team might be referring into, and we need to streamline that as much as possible, and that benefits patients in Brighton and Hove as well. So we're working with our colleagues across Sussex, because we have a hospice alliance in Sussex for all of the adult hospices, to look at how we can better work to create a referral process that's much easier for our hospital colleagues, and also meets the requirements that we have as well. So we will always look at ways to work together, and similarly with Lisa and the community, the SPFT, community services, we would absolutely do the same.
Can I come in as I say, thank you for your question. For me, part of your question probably links or alludes to how we manage our clinical governance within the organisation. And oftentimes people kind of shy away from clinical governance. It's something that I think in my role I've actively embraced as we've become one big organisation. And how do we learn from what we know and what we understand? So what do we know from our patient experiences, and how do we gain our patient experience feedback? And more often than not, we get that through complaints and data. But actually there's a richness in that information that we get that tells us what we can do better. But that on its own doesn't help us. So we link that into what we understand ourselves through our data system within the hospital. So we link those complaints to the data and the concerns that we evaluate of our own actions. And then more recently and novelly, I think Brighton's at the forefront of having a medical examiner role within its organisation for Sussex that extends into the community. That allows us to look at learning from death. So we're able to then triangulate the complaints, the data that we raise about issues that we have within the hospital, and we can link it to the independent review from the medical examiners, where they've spoken to the relatives of the deceased. So we get that level of feedback as well. And alongside the concerns that are raised, what's reassuring for us as an end-of-life care governance group within the hospital that we then shared to the oversight group is the amount of plaudits that happen alongside it. The number of plaudits we get independently from the medical examiners oftentimes far outweigh those complaints. We take them both very, very seriously because we can learn from what we do well and replicate it, and we can learn from the concerns that people have raised and change that. The reason I say that in terms of the collaboration is the end-of-life care group in the hospital has representation from the hospice, from the ICB and from SCFT, so that then when we go to the oversight group, we're all already knowing what we're talking about from that governance perspective. Does that answer the question? I won't.
Can I just add to what my colleagues have said? I think another measure is, and it's in the paper, it's really recognized that most people prefer to die at home. So if you look at the data, it shows that actually Brighton benchmarks well. Doesn't mean there isn't room for improvement. And the whole aim is, what can we do to avoid admission? And that's where the respect, and Lisa talked about the hospice at home. It's not just about beds. You talked about what the community nurses do. But then if they end up in acute hospital, how can we get them out as soon as possible? And you saw that with the case study example we gave you. Fast track also, what they do to make sure you can fast track people out of the hospital. So I would say the two key evaluating measures are really admission avoidance, and we should be improving on that trajectory so that people only go to an acute hospital if they really have to. And if they do end up there, how quickly do we get them out? That is how you measure our joint working together, because it requires everybody across that pathway. I hope that helps.
Can I just come back on that? It's just, so I've been through this experience myself. My husband had palliative care at home and it was his choice. I was really, really scared of that, and I let him have his own choice, which I think in the end was a really good experience. If you can say that, I've got nothing to complain about. I thought it was absolutely the right thing to do. But speaking to other people where it's happened to, possibly they've had the home death and it's been the wrong choice for the carer, because she had a friend of mine had a really traumatic experience. So I know that the patients are given the choice, but I mean, do you talk it through with those carers? Because sometimes they don't really know what they're going to have to deal with, and they do find that quite traumatic sometimes. And I had help because my daughter actually worked in a care home, so she'd been through it. So that's why it was okay for me, because not only do I have the great experience of Mark there, so I also have my daughter there. Thank you.
Thank you, and thank you for sharing that. To say that, yes, we absolutely recognise that there can be huge complexity in what that individual patient's choice would be, and actually how feasible it is to support that choice dependent on their needs, the social situation, the home situation. So we do work, we review every single community case that we have under our care every day. We have something called a huddle every morning where all of the key priority patients who are in the community are discussed in the hospice. And we absolutely work with our colleagues in SDFT, because we also collaborate where there's concerns about the home situation or how well we can actually support those patients, where the community teams can also support that patient. And if it is becoming very difficult, then yes, we work closely with the friends and family. We have to respect a patient's wishes. If they have capacity, we can't enforce decisions on them, but we absolutely would work with the family and friends and carers of that person to try and come to the best possible conclusion for everyone concerned.
And would they get more help if they needed it?
So the challenge is availability at times. So we have a hospice at home team that provide support out of hours. And obviously we have our colleagues who are the district nursing teams who also support with those patients. We have limited resources across all of those teams. So we have to do what we can with what we have. And at times that does mean we have to support and encourage a decision that potentially they need to come in for or a period of care within the hospice, which obviously will usually be the preference. We would do everything we could to avoid having to send them to the acute side, because that wouldn't usually be most people's choice and it wouldn't be what we would be trying to facilitate. So it does vary, but we manage every patient case as an individual case, and we look at all of the aspects of that patient's care that needs to be considered.
Thank you. I think I've got Nora next. Oh, I haven't got. You put your hands up together, so whoever wants to start there.
Thank you very much for coming in. I've never known anyone working in the hospice movement who is there for wrong reasons. But I knew Joanne, Harvard Beringer's wife. She was a long-standing officer in this council and very distinguished as well. But there were two things. I mean, Chair referred to "you being a naughty girl" quote from a surgeon, which was just so inappropriate. Jo came into Health Watch to give her side to see what we could learn from it. But there are other issues. Same-sex couples still come across barriers, and that emerged out of this case study as well. So how you educate people to address these issues in a more sensitive way without putting their foot in it is, I don't know, it's an ongoing task. I mean, I had the privilege of working with Dame Cecily Saunders, who set up the hospice movement in 1967, and she would be, I mean, amazed by what her idea has developed. But, and in the main, people have nothing but praise. But when things go wrong, it really does hit a raw nerve with everyone. And I don't know how you just continue the education process of all people who come into the hospice sphere and deal with patients to give them the best ending.
Thank you, Jeffrey. I mirror your appreciation of Dame Cicely Saunders. I didn't have the pleasure of meeting her, but I did have the pleasure of working at St Christopher's for a very short period of time. One of the things that I think all of us do within palliative care is we promote the education that we have to provide. And our toolkit is our ability to communicate and our ability in terms of how we behave with empathy and with compassion. And one of the things that we endeavour to do at Sussex since we've merged is bring all of our education training together around palliative and end-of-life care. And it's one day study day that we run across the organisation is Dame Cicely Saunders telling us you only die once and you matter because you are you. So we try and reframe and refresh things that we've known for many years and bring it into that kind of the modern challenges of healthcare within an acute, within hospice and within those areas, and how we identify the founding principles of holistic care are the individual that we're looking after and those that are important to them. So, you know, we try our best to ensure that we educate. And over this last year, we've managed to provide that one-day study day to well over 200 people within the acute now that work in all different sectors and spheres within Sussex. We want to, when people ask us, increase the amount that they can do themselves as link nurses so that we're promoting those very same principles around holistic care. And for those that want to, we have a 5-day course to go on, where at the basis of it is the one thing we can teach people symptom control, we can teach people things that quite readily easily, but what we want to ensure is we teach people how to communicate with the individual, and at the basis of that is our compassion and our empathy. And we endeavour that that's the part to do, so much so that Prof. Urch has given us the support that we provide communication skills training as much as we can to those that want it.
I mean, one of the things that distinguished Jo's presentation to this committee was that she was supported by the British Liver Trust. And I just wonder how much work you do with patient groups like that, because they will have real insight into the impact of end-of-life care from a patient perspective. And I think you only have to push on the door, it'll open, and they'll be there to help you.
So I think we alluded to that at the beginning. One of the things that we are very aware of is the way that our pathways for end-stage liver disease need to change across UH Sussex. So we're in the early stages of looking at how we can develop those better. And in those initial kind of focus groups, we're going to make sure that we have the right people there. And I think that's something that you're very keen on starting. So Lisa's kind of coordinating that, because it feels like it's a very community-centric start of the process that the acute feeds into. So from the acute trust, so I'm part of that collaboration, but in there we're going to make sure that we do have our colleagues from those particular associations as well.
Yeah, we have already reached out to some of them, so we're waiting for a response to see, but I'm very confident that they'll come and join us, and we'll welcome all of them to come on. I just wanted to say that Jo and Joanne's story, that end-stage liver pathway that we're working on, is a direct result of that HOF report that has been widely shared. I mean, we've all seen it, we've all read it, we've all cried over it, we've shared it widely with our clinicians. Makes me shiver now talking about it. And what was I going to say? And yes, so that's a direct result of that report coming here and being shared widely. That we have decided to do that piece of work to try and hold people a little bit more confidently and support their carers and loved ones in the community and in hospital, and to make sure that they are treated with dignity and respect, and they don't keep bouncing in and out of hospital, because our pathway is robust enough to support them at home. That answer your question? Yeah. Okay.
Thank you. Right.
Thank you very much. Actually, I want to follow on what was just mentioned, and obviously the case study was, like you said, it's been shared and changes have been made, which is really great. That's what we want to hear, that when things happen, that you then, do something about it. Is that the same for people who have cultural or religious needs as well? Because I know from people whose English is not their first language that they often struggle, misunderstandings, some want to be more at home. Sometimes they don't understand the palliative care that you can get from, for instance, Martlets. So they think it's the best way, it's the best to do at home. So you mentioned something about a focus group. And did I understand correctly that it's about bringing patients on there, or is it for clinicians?
So, yeah, in answer to your question, yes, that's another very, very huge focus of our work, to ensure that we're respectful and knowledgeable about different faiths and cultures, and that everyone is included and has access to the same materials, no matter what faith or religion they are. We've got, I know all of our organisation have a spiritual lead. who has named people that we can call on for different faiths, etc. So in our trust, for example, we have managed to identify different faith leaders, and we've recorded a suite of videos, I'll call it, with different faith leaders discussing with our spiritual care lead and myself what actually is important to you and your faith, because something like lighting a candle and facing a certain direction is very important. But if our clinicians aren't aware of that, then the spiritual nature of someone's end of life can be very different. So we're trying to develop lots and lots of resources like that between us all, so that people have equitable care, ideally. Yeah, and the focus. But yeah, go on, you carry on. Speak.
I was just going to say, so I think it's probably across all of our organisations, we're very much looking at where we have health inequalities and access inequalities, so be that by region or by population groups. So absolutely that is a priority for us to see how we can do better, because we know there's still a lot of work to be done there.
Oh, focus group. Yeah, sorry, I went off on a tangent again, didn't I? So focus group, yes. Focus group is with patients with lived experience and carers of previous patients with lived experience who are invited in, and we learn from them, basically, from how they found their journey, what we can do to improve, what went well, what didn't go well, and yeah, take that very seriously. Sorry.
So just to, because I know from experience that often people from the Black and racialised minorities, sometimes it's more difficult to engage them in focus groups and things. So are you making sure that the focus group is more representative of the community, and you're putting measures in place to ensure that happens? Oh, sorry.
Oh, sorry. Absolutely, we are, yeah. And we are actively recruiting all sorts of different people so that we are represented widely on that group. But yes, it's a work in progress.
Thank you. I've got one more question, which will be quick. It's so I'm a representative for Community Works, so I represent the community voluntary sector. And one of the questions that came up was around the respect form. And currently, filling out the respect form is very patchy. So some people get really good support in filling out the form and all the next steps, and some don't. And she was mentioned to me that we still need more people to support with that process. Is there a plan in place to make sure that that's more streamlined or made easier for patients?
Yeah, so you would notice from the paper that we commission the locally commissioned service, so that actually GPs are able to spend more time doing it. It's obviously work in progress in terms of improvement, and you heard from the colleagues where if you look at a patient who ended up in hospital, you look at the respect form and you feed back to the GPs on what can be done to improve that. So it's ongoing work to improve, but the numbers, as you saw from the paper, I think we highlighted the numbers that had been completed over the last few years, which showed an increase I'm trying to look at the paper at the same time, which showed an increase in the number of respect forms being filled. We are currently revising our locally commissioned service for frailty to ensure that actually it's not just seen from palliative care, but it's also seen from a frailty point of view. So because otherwise you focus on the people who are dying, but frail people, as we know, are also on that trajectory, and so it needs constant revising. Okay, thank you. Raphael.
Thank you. I think already kind of touched on this a fair bit. I think Jeffrey's question kind of was what I was originally going to ask, so slightly rephrasing it a bit. But I'm interested in what you're looking at in terms of sort of training around support broadly for LGBT plus people, and kind of how, yeah, I guess particularly for trans people, but also people who might have multiple partners if they're in a polyamorous relationship, for instance. Because we kind of saw in the previous example with Joe, kind of difficulties of accessing support as a partner in a way, and sort of being fully validated in that position. So I'd just be interested to hear a bit more about that. I know that's sort of a few different topics, but I'd be interested to touch upon that in some way.
So we probably need to do that a bit by organisation, just because obviously there will be some variation about how we're approaching it. So from a hospice perspective, we are very focused on a holistic approach, and we very much are focused on what matters to that person, and ensuring that we understand who those important people are for them, what their requirements are as an individual, and we really do everything we can to ensure that we support them to live their life how they wish to live it in the period leading up to end of life and during end of life. So if, for example, we have someone who comes into the hospice and is having inpatient care with us, then we absolutely have a section as one of the things that we ask: what matters to you most, who matters to you most, and what are the things that we can help facilitate for you in those last days of life, if it is that close to death. And we will do a lot of work to really support that individual to have the input and fulfill their wishes as best we can, to do those few things that potentially they want to do. For example, we've had patients who wanted to be able to get to a football match, who wanted to be able to get home for a child's birthday, or whatever that is. We will ask them and work with them to do that. And we have a whole team we have counsellors, we have spiritual support, we have bereavement services, etc. So we absolutely will focus on that person as an individual.
I think that comes back to that principle we talked about: you matter because you are you. And I think in the palliative and end of life care training that we offer from Sussex, one of our full days is committed to that holistic approach, which does get the cohort of participants to really think outside of the box to how do we really know the person that we're looking at. And I think that comes to what you were talking about, Raphael, a little bit, is it's about that curiosity that we have as healthcare professionals. But even when we have a really busy time of looking after 30 people in a corridor, so how do we make sure that you don't lose sight of that one person in the bed next to the other 29? And one of the things I think is really important, and it's in its infancy within the hospital, is how do we triangulate, again, that work that we're doing around behaviours into the work that the organisation is wanting to promote around equality and diversity and everything that matters there to those persons that really feel marginalised within society. And how do we celebrate the richness of our cultures and people's chosen identities? And we live in Brighton. That's something we should all be celebrating. And I hope that Sussex as an organisation is part of that. I feel it is, from my perspective, from within the organisation. There's more to do as we understand and learn more. So hopefully we'll get there. Does that answer your question from my perspective?
Yeah, I mean, I think it is a very individual process. So in a way, although there's sort of all of these different permutations of identities and things we can go into, it is, if you're dealing with everything on an individual basis, I appreciate you should be able to pick up all of these things. I guess it's just ensuring that staff have prior awareness around, these things, I think is what we want to ensure, essentially. But yeah, thank you for, yes, please.
Sorry, I just wanted to add from a community perspective. So again, very timely question, because that's another strand of work that we're developing in the community with our LGBTQ network within our trust. And I've presented some of these case studies to that network group, who have then come onto our patient experience group as well. So it's brilliant to have them represented on our group. Also, we have specific training funded by the ICB and given by the hospices, so our specialist providers, on specific inclusion health as well. So our clinicians are getting that training as well, and that in-depth knowledge about what matters to each individual.
Gary.
Thank you, Chair. Yes, I'll just come back to you with a quite a quick question, really. And just to help to get a sense of the areas of greatest need for care and the services you provide in our city, Brighton and Hove. So my question is, how is population need measured? Is there a central point of collecting this data? Because I've looked in your overview section of the presentation paper, and we previously talked today about inequalities. So related to that, do you measure age, social class, ethnic background, and where's that collected and shared amongst yourselves? Because I know in the overview you just talk about deaths in care or at home, but you must obviously be collecting other data, and I'm sure it's there. It's just to clarify where it is, and kind of allied to that. Just the last question is, in terms of people accessing care and support and information about the services you all provide, is there one-stop shop, for example, that people can go to navigate through what can be a very complex system, especially in times of crisis or need? To signpost people where to go to access all your services, as you're all quite separate in some ways. And if there is, where is it and how do people access it? So there's a number of questions there. You might want to split them up. Thank you.
Thank you, Councillor. In terms of need, we've actually started a discussion with the Hospice Alliance, and we will need to engage with our local authority colleagues, public health, because it's what you're asking for is a joint needs assessment, and they're the experts. So that's something that we've got down as the Hospice Alliance and what we want to do, because the providers and primary care will only look at demand. They won't look at need, it's who comes to them. However, as we have aging population and things like that, we need to start planning for what does the future look like. And that's a discussion we will be having with ourselves and the Hospice Alliance with our public health colleagues at the local authority.
Just to add that, so the Hospice Alliance is a collaboration between the 6 adult hospices that sit within Sussex, because we recognise as individual organisations that there is a stronger voice if we collaborate, and it's also a better process from the side of the ICB that we are able to talk more with one voice. And so we're doing a lot of work, as Lola alluded to, looking at what the data is available, how we can utilise that data, what actually should we be capturing as hospices on a regular basis for the population that we serve. And we're doing that's a very active piece of work that we're doing currently, so that we can feed back into therefore what is needed across Sussex. And we do very much look at our population. So as a group of hospices in Southern Hospice Group, just to be confusing, we're part of the Alliance, but we're a group of hospices that now sit under one structure. We are absolutely looking at and very mindful of what is the population of Brighton and Hove when we compare it to the population of Worthing. Where do we need to consider differences in the service provision that we give by our individual sites? So whilst we have merged as hospices, we recognise the importance of retaining that individual approach and really pinning down what our needs are for our population that we serve.
And just to go back to another question asked in there, there was a few. Is there a signposted route for people in the city to get information about your services rather than just going to your sector? Is there a central point of contact, as it were? Thank you.
So, thank you, Councillor. I was going to wait till the end to talk about Dying Matters Awareness Week, which I was going to get Helen to say a few words. But one of those things, as one of the outputs from that, is a booklet we have worked with our clinical leads on what are the various services available, and that will have like a central point. I'll probably let Helen say a few words about what Dying Matters Week, because I was going to actually ask that councillors also can help create awareness of that. And it's going to be a national thing between the 5th to 11th of May. Maybe Helen can say a few words on what it is. But the output of that is in one place, we have a booklet that actually will list all the services, because, I mean, dying does matter. I don't want to, it's a cliche, but it does matter. You know, and making sure people die well does matter. Helen, do you want to say a few things about what Dying Matters?
Happy to. So in terms of a booklet of services available, we've actually developed, it was intended more for carers, but it obviously would work for patients too. And that resource is held with each of the 3 place-based carers hubs, so West Sussex, Brighton and Hove, and East Sussex. So that's available, that does provide information for patients and carers. In terms of Dying Matters, it's sorry, I struggle with glasses. It's a national campaign that's led by Hospice UK to try and create an open culture in which we feel comfortable talking about death, dying and grief. But each year there's an annual week of Dying Matters awareness, which actually times well with this because it's the week commencing the 5th of May, and this year the theme is the culture of dying matters. So a bit of a spoiler for my colleagues that are coming to the oversight group next week, which is the Pan Sussex multi-stakeholder oversight group. We will be able to release in time for the Culture of Dying Matters Awareness Week a new resource, which will both be available on our intranet and also as a PDF booklet resource, which is all about how to support staff to individualise care, to respect patients' cultures and faiths at the end of life. So after a lot of work over the last 2 to 3 years from one of my colleagues, particularly in the ICB, that will be being shared next week at the Oversight Group and then championed across the system during Dying Matters Week. Our comms team will be developing a whole strategy, including social media releases, and they'll be working with the comms teams in other organisations to support the sharing of that resource and promoting that culture of dying matters.
Thank you. Has anybody got any more questions? No, one more. It's in the bath.
Thank you, Chair. It's not a question per se, and I was waiting until other councillors had a chance to ask any remaining questions. I just want to give an overview. I find it really reassuring to have heard of all the positive things that are going on and the services that you are all providing. And I do take note of the need to carry on with the work in terms of assessment of needs, which we talked about earlier, and coordinating your approach, which was in the early stages. So I guess my ask is to the committee and yourselves, whether you'd be willing to come back at some point in the future, just to give us an update on the progress of them 2 main areas in particular. And, you know, given that there are new challenges that will be facing us all in terms of assisted dying and stuff like that, these are all going to impact on your 5-year strategy, which may become a 7-year strategy, because you'll have to incorporate that in some shape or form. It'd be really useful to have you back just to hear about how you're taking that on board. And personally, thank you for coming on today.
My colleague said they would love to, so.
Okay, thank you. Thank you very much for coming along and asking all our questions. And now I would like to just call this meeting to a close. Thank you.